Good afternoon. My name is Katie Coleman, and I am excited to be here today to celebrate LEAP and all the many interesting findings that have emerged from you high-performing teams. One of those interesting findings being about how to sustain great team-based care. So as you all well know, LEAP practices were selected to represent a range of practice types, large and small, independent and affiliated practices, private practices, and federally qualified health centers. And one of the interesting effects of that has been learning about how practices with really different payer mixes and financing structures have managed both to develop and to sustain team-based care over time. So on the next slide, you'll see a chart that shows the responses from a survey you all recently completed that asked about how your clinical and financial and other outcomes are doing now in late 2016 was when the survey was administered compared to 2013. And the first thing I think that is of note is that almost all of you managed to continue to improve clinical outcomes, even in the face of growing patient volume and sustained or better patient experience and staff experience. I think this might be perhaps in part due to kind of a services first leadership mentality, a leadership strength that we know in these LEAP sites, understands what high quality comprehensive primary care is and goes about making that happen. Which is not to say that paying for non-provider staff and non-face-to-face encounters is easy. In fact, a recent article estimates that doing patient-centered medical home style care costs $105,000 per provider per year. And indeed, 5 practices said that their financial structure was worse now in 2016 than it was when we first site visited folks. The sites that responded that way were varied. There was a large system, 3 medium and small private practices, and 1 federally qualified health center. In large part, you all said that that had to do with decreased reimbursement rates, mostly in Medicare, inadequate or inconsistent quality-based payments, and increased workload to meet external requirements. Which is not to say that there weren't some good benefits that happened over the last 3 years as regards to revenue. Perhaps not surprisingly, 5 practices called out the specific power of the Medicaid expansion in their states. And indeed, of the 20 states represented in LEAP, 16 of them were Medicaid expansion states. For those of you that serve a high proportion of Medicaid patients, especially federally qualified health centers, this enhanced reimbursement was really important. On the next slide, please. So Medicaid expansion was certainly one important new revenue stream, but there were lots of creative revenue streams that you all mentioned you were taking advantage of to support your team-based care work and your comprehensive primary care design. Some of them were delivery system innovations. People talked about productivity and efficiency gains by using scribes, or taking advantage of billable encounters for behavioral health folks. Many of you captured new reimbursement through Medicaid expansion, as we mentioned, or new Medicare nursing codes that were able to be applied outside of a provider visit. Several of you shared services with partnerships with hospitals or social service agencies in your communities, with one site really radically rethinking their relationship with their hospital in the face of declining ambulatory care sensitive admissions. Many of you partnered for financial opportunities through ACOs, through quality and payment-based demonstrations like CPCI, and through creative partnerships with your health plans. Interesting, some of you noted the challenges of the lumpiness of the payments as related to value-based pay that made planning difficult, and perhaps the mechanism of those enhanced revenue streams was a challenge in and of itself. Finally, you all were really creative in terms of seeking out support for high quality staffing. Many of you talked about going after residency funding or training or volunteer programs as a means to build out rich, high quality staff. So on the next slide, here's just a quick summary that we heard from you all about the many interesting partnership arrangements and payment arrangements and new processes you undertook in the last few years. In our discussion time, after we hear a little bit from Tom and from Michael, I'd love to hear more about the benefits or challenges related to these new arrangements. For practices that have been experimenting with value-based pay, for example, have you been able to demonstrate new money? What infrastructure has it taken for you to be able to capture those payments? And for those of you with new partnerships, how have they gone? Have the ACOs paid out and have the acquisitions or other new practices that you've worked with, have those been beneficial to you in sustaining team-based care? So I'd really be interested in hearing more about your experiences with these payments and processes and partnerships that you've undertaken. But before we get to that, I'd like to turn it over to Tom for his comments.
Thank you, Katie. Since the LEAP visits ended, I've had the opportunity to visit about 15 more excellent practices around the country, what I call bright spot practices. And
Tom, I'm gonna interrupt you for 1 second, and Katie, I'm gonna ask you to click on Tom's face and spotlight him, so you don't have to look at me while Tom's speaking. You just have to click spotlight video onto Tom. There we go. Thank you.
Oh, that looks a lot worse. Okay. So anyway, I've had the opportunity to visit new bright spot practices, and they really corroborated something that I learned from the LEAP visits, which is that a core team with a stable 1-to-1 MA clinician ratio is good, but 2 MAs per clinician is better. And the additional MA with excellent training can do scribing, panel management, and health coaching, improving all 4 of the quadruple aim metrics. In particular, having the extra staff greatly reduces burnout, and burnout is a very important barrier to sustainability. Now, I know that adding additional core team members is risky, and the chief financial officer needs to be involved from the start, and there needs to be an airtight business case for the additional personnel. But with 2 team members per clinician on the core team, everyone on the team has more fulfilling work and lower burnout. The clinicians are generally happy to see more patients to pay for the expanded core team. Then you can financially sustain the expanded core team for the future. Now, can everyone do this, and should everyone do this? Probably not, but it's another opportunity to add to LEAP's wonderful encyclopedia of sustainable team-based care. Thank you.
Thanks, Tom. Is Michael still with us?
Yes, he is.
I'm here.
Your thoughts, Michael?
Okay, so a few observations in terms of what I see going on specific to payment models for primary care. The first is, I would say that to a significant degree, for some payers, the bloom is off the rose for the patient-centered medical home a little bit. And I don't view that as actually as surprising, because we're prone towards fads in health policy in the United States, and patient-centered medical home was a hot fad for a long time. I think that there are still some payers and provider organizations that view a patient-centered medical home and primary care in general as being foundational to good population-based care, but the clear focus of many payers right now is to enter into total cost of care, population-based payment arrangements, and not to focus solely or even primarily on primary care. In some cases, payers are doing that, acknowledging that primary care is an important foundation, but I have to say in some other cases, they're really focusing on contracting with large systems or IPAs in total cost of care arrangements without much special thought to primary care. And so I find that to be a mixed bag. It varies regionally and by payer. And, for those payers that really believe that all that's important is that you've got an ACO that knows how to do centralized care management, obviously that's not a good step forward. In terms of payment, I see a move back to, when I say that, I mean for most of the country, back to primary care capitation slowly. Now, certainly there are parts of the region, especially of the nation, especially on the West Coast, where capitation stayed active for a long time. But primary care capitation, when it's being implemented now, always has a performance component. So that's typically a supplemental payment. That's a quality incentive, but it may also take into account heavy use of referral services or primary care practice, referring out a lot of primary care. So this is sort of a little bit of a return to the future, but in those parts of the country where primary care capitation never went away, it means introducing quality into the payment model in a way that hasn't existed for the last couple of decades while that model has been around. So that to me is a new trend, and I think that there are some payers who recognize that even if they enter into a total cost of care arrangement with an ACO or ACO-like entity, it still is important to look at what are the underlying payments that are being made to primary care practices, specialists, and hospitals. And those payers are being thoughtful and mindful about their primary care payment models. But I can't say that they are all operating that way.
Thanks, Michael. Let's hear from others. Katie framed some questions. What's been your experience with value-based or capitated payment arrangements? What's been your experience with new partnership arrangements like ACOs? We want to hear from you.
And as a reminder to those who are viewing, you can raise your hand, send in a Q&A, or send me a chat, and we will promote you. We have someone asking.
And, while you're pulling up that question, Ed and Mike and Tom and folks, I think Medicaid is really joining onto this issue. We know that Medicaid faces big challenges coming down the road, but we are seeing in our home state, as well as in other states around the country, a real drive towards looking at shared savings, but doing it through the lens of quality, and how anyone would achieve those quality measures without team-based care in place is a big mystery to me, whether it's integrated behavioral health or it's the expanded role of the MA or it's the data-driven quality improvement. Question? Chris?
So can you guys hear me okay?
Yes, we can.
Okay, so we're in Western Wisconsin. We're a small, privately run rural clinic. We did a shared savings program with one of the local plans, one of the local health plans. We were able to finally get information we were looking for as to which cardiologists were less expensive, which orthopedics were less expensive, and still made it to quality. So from that standpoint, we actually improved our quality and cut our costs by 9%, which is actually pretty substantial. The problem is it required us to not always refer to our hospital. And our hospital's response was to build a clinic in our backyard and compete head to head with us. And so, it definitely is a mixed bag. But from our patient standpoint, I think they definitely win. They get as good or better care for at least a 10% savings, which to me is pretty significant.
Thanks, Chris. Other comments?
It's a quiet group today, but this is the last chance to engage in the dialogue with your Leapster colleagues. So we really encourage you to chime in if you'd like.
Well, Julie sent in a comment and she said, we have found at our practice, Marymount Family Medicine in Colorado, that the ACOs have not been very effective. We found that we have to depend on other outside groups that did not meet the thresholds for payment while our group did. But because of the other groups, we did not receive any funding. And we also have another, Kirsten is being promoted to a panelist and she has a comment as well. Kirsten, you are on.
Hi guys, can you hear me?
Yes, perfect.
Awesome. So Cambridge Health Alliance has wound up now with the coming year something close to 80% value-based payments, which is a substantial amount. And of course, it's all a mixed bag of all the different kinds of payments one could have. But I would say for, from the primary care perspective, the most wonderful part of being in what I call a baby ACO has been that really we've been able to give incredibly high quality care to our patients. I can simply ask an endocrinologist's opinion on a confusing thyroid issue from a patient that just transferred care to me and allow the person to go on vacation, right? Rather than waiting around for 2 months to get an appointment because she's terrified she has cancer. We've been able to do that with decreasing costs, which of course is one of those tricky things where if you keep decreasing our payments, eventually we're gonna start to squirm, but so far so good. I'd say at least in Cambridge and Somerville, Massachusetts, and what we call the MCRU area, Revere and Everett and the greater Boston area, it's actually been an incredible boon to the quality of care that I think I give and the happiness that I experience at the end of the day.
Thanks, Kirsten. I'd like to hear more about the comment actually that preceded Kirsten's about from the practice that was participating in shared savings, reduced their share of utilization, but didn't appreciate any financial gain. We are hearing stories like this now in our travels around the country. And Michael or others, is there a real epidemic of failures to appreciate value going on here?
I have a couple thoughts. Can you hear me?
Yeah, go ahead.
Right. So a couple things. So first, we're really going through growing pains nationally in terms of figuring out how to make these value-based payment arrangements work. And so there are going to be some stub toes. But I would say, when I say learning, I mean the payers are learning every bit as much as the practices are. So that's one thought. The second thought is these value-based payment arrangements don't work at a statistical level very well for small practices. Because when you're looking at cost and utilization for a small patient population, there's a lot of random variation and white noise. And so you either get lots of swings up and down that don't seem to make sense, or in the case that I think you might be referencing, Ed, sometimes the payers say, well, you're too small, so I can't judge you on your own, so I've got to group you together with other practices. And then your fate is tied into other practices who you have no operational relationship with, and you don't really know that they're doing the same thing that you're doing. So I think two issues here: one, growing pains, and two, the challenge of using value-based payment models with primary care practices that do not have large populations and hence have statistical variability.
That makes sense, but it is interesting that all of these so-called startup errors are in the direction of withholding money from primary care.
Well, no, I think there's some primary care practices that also benefit. I mean, there are some winners too. I wouldn't say it all goes in one direction.
This is Tom.
Tom?
most ACOs, and Michael, correct me if I'm wrong, but most ACOs are hospital run, hospital controlled. So the question is, where does the shared savings go? Does it go to primary care, specialists, inpatient services? So there are some ACOs that are physician controlled, and a few of these are controlled by primary care. And I would think that a primary care controlled ACO would have a better chance of having shared savings go to the primary care practices.
Well, in fact, the evaluations of the early evaluations of the Medicare ACOs show that the physician-controlled ACOs did better than the hospital-controlled ACOs. To your point, Tom.
Right.
Yeah, not surprising. Other comments from Leap
Can you guys hear me?
Yes.
Yes.
Andy.
Hey, how are you guys?
Hey, Andy.
Hey, Andy.
Nice to see you all. So just a couple of stories I've shared and some to pick up on some of the comments that were made. We've actually been involved, I think, at Dartmouth here in two ACOs. I know. We were sort of part of that original group of Pioneer, and we suffered a little bit about what Michael is talking about. In Keene, in our portion, we were able to meet all the quality metrics and actually able to meet the utilization measures that were set before us, but the larger system was not able to. And so we retroactively pulled out of Pioneer in October of 15. And so that was problematic because we had done all this work, hired staff to achieve certain goals, and actually met all of those goals. But just to give you a demonstration, as the larger organization did not meet those, we did not receive any payment. So now we're back in with them because we're in next gen now, and there's a different payment model and a different structure around that, and they're trying to be a little bit more clear on those guidelines. But they're already starting measurement, as I'm sure you all know, as of January of 17. The second thing I think has been fairly interesting is this idea of population health. So I know when I got heavily involved with LEAP and really enjoyed learning, population health was really something that was primary care. You know, we focused on this, we created processes here to help with that. But over time, what I've noticed, at least in our organization, is population health has become its own department. And that's concerning to me because when we win in these ACOs, that's where I see the money going. They go into this population health place, and that's not always inclusive of primary care where the work is being done on the ground. And I have some concerns about what that might mean in the future if we continue to develop strategies in larger organizations where population health is its own department, and the people doing the work on the ground and connecting with patients, which is really where the feel good is primary care or specialty. But if the payments don't come that way, you can't really make your zero cost that you're trying. And the last thing I would say is that we have had a lot of success here. So when we started to look and analyze our local financial data here with our chronic disease model, our care transitions and care coordination involving 2 social workers we now have doing behavioral health. Since we've been involved with LEAP, we've reduced the per member per month cost of all patients that come to the Keene Clinic by 15% over the last 2.5 years. So I think for us, it's been a real win. We're a unique situation where there's not a lot of local competition here, but we are part of a larger system. But it's been fascinating to watch this change.
Thanks, Andy. Other comments?
I'll share, Ed, that I have seen in some ACOs this tendency in some cases to take primary care functions and to centralize them and develop specialized teams to do what we actually think should be in a primary care practice.
And I can comment on that because we've actually been standing against that within our system. We are, because of our local connection with our hospital, we're able to sort of push back on that because we've actually tried centralizing it locally, even within our own department here. When it was not connected to PCPs, patients were very dissatisfied with that care. And so we took it apart and rebuilt team-based care out of that about 4 years ago. And it's a battle because they're trying to do exactly what you're talking about. They're trying to centralize care coordination, centralize patient data functions, and centralize chronic disease management. And it doesn't work well, at least according to our patients, because we're surveying them regularly.
It also doesn't work well according to the literature, Andy.
Yeah, I agree. And we've shared that as well.
Tiffany, you're up.
So this is Linda Thomas and Tiffany from the Wright Center. Hi, everybody. So our experience has been really interesting in Pennsylvania. When the state level forum went away, we actually lost the forum that gave us an aggressive edge to change the conversation with the provider and payer community. And what we found is that most of the practices that we're innovating within the Chronic Care Collaborative here in the state of Pennsylvania are now independently advocating for payer-driven contracts to get us to value. So we joined an ACO. That's a very interesting regional dynamic. It's part of the Geisinger ACO. So I think as a participating non-Geisinger provider, we're still finding our way, just because it's an eclectic group of different organizations all trying to align around a collective framework that in large part is being driven by Geisinger. So we're having those conversations. Our greatest leap forward, I think, in the last 2 years for value-based payment reform, interestingly enough, has just been following the guided pathway of Medicare. And, you know, Medicare's jump into value-based initiatives that came through the volume world in terms of the annual well visit and screening for depression, so the integration of behavioral health screens, functional status, advanced care planning, and also their care management payments that just received a very robust expansion in January of this year, have actually been the payment changes driven by Medicare, which some of the payers are following, that have actually allowed most of the innovations taking place in the Right Center within the past 2 years. So really interesting that all of these opportunities for value-based payments, probably dependent on where you are in the country. But when we lost the neutral state forum, most of the drive in our everyday world in the trenches has been at the federal level, just in terms of Medicare payment reform.
Linda, that's fascinating because Medicare reduced reimbursement was a problem for some other practices. I wonder if any of them are on the phone.
It's really interesting, and you know, just to fill in that place too, in the Affordable Care Act, the 2 years of Medicaid parity, where Medicaid actually started paying Medicare rates, really was beneficial to the Right Center. And the loss of Medicare parity when the 2-year window went away really hurt us, particularly in the hospital admission side. I mean, we saw reductions in payment tenfold, you know, in terms of payments for hospital visits, but honestly, we're getting smaller in the hospitals because we're getting more robust in community-based settings. And the changes that came, particularly with the care management infrastructure, we learned a lot from CARE South Carolina and Ann Lewis. I think she was one of the lead practices, so she really helped us by sharing her curriculum and actually showing us some of her business model. But we've really capitalized on that advancement of Medicare, which we're assuming may slow down a little bit. But
yeah, that's great. Is anybody from CARE South on the phone? Other comments?
This is Tom. I wanted to follow up on what Linda was saying, which is, you know, the dominant payment mechanism is still fee for service. And if you want to have 2 medical assistants to do your scribing and panel management and health coaching per clinician, the way that practices that are doing it, most of them are actually paying for it by having clinicians see more patients. It doesn't take many more patients per day to pay for an extra medical assistant, and also billing more 99214s because your documentation is so excellent, because you have someone to do your documentation helping you. So that's sort of, I think, a lot of times the way that a lot of these improvements in being able to have a larger core team are really financed, rather than the alternative payment mechanisms that we're still, you know, we're not sure what's going to happen with that.
Thanks, Tom.
And we do have folks from CARE South on, and I've unmuted them. Anne, are you there?
Anne, you're on.
Oh, we can't hear her.
But we see you, Ann.
We can see you, Anne. We just can't hear you. Maybe you don't have a microphone yet.
oh, there's Dan.
So maybe while we're waiting for her to get a microphone set up, if there are other comments.
I can fill in. This is Linda Thomas from the Wright Center again. I should have taken note too. The other fueling source of resource engine for us has been trying to figure out how to get around the carve out for behavioral and mental health services within the state Medicaid program. And what we're finding is that the belief that they were completely fragmented and isolated in the year 2017 does have some workarounds if you have some collaboration at the level of the state and with some of the payers. So we've done a lot of innovation, particularly in the space of opiate management and opiate addiction, trying to get resources on the medical side for the behavioral health integrated services from the behavioral health payer world. And that's been very helpful to us in terms of conversations.
Great. Ed, I think the hour, sorry. All right, there's quite an echo there. Ed, I think the hour is growing short because we got a late start, and I wonder if this is a good time to transition into our wrap up for the LEAP project.
I think it is.
Good. So we, today was filled with challenges by starting late due to some unforeseen tech issues, but we intentionally invited to this last meeting of the LEAP community, and it really has become a community, just the LEAPsters, right? Just the LEAP organizations. And Michael, we made you an honorary LEAP person if you weren't one before, because we wanted to take time to acknowledge this. And Rima, can you cue up our photos? I'm going to allow Rima to run this photo show while we say a few words about what this has meant to us. You know, every great idea begins with a leap of faith. And that leap of faith, if you're lucky, turns into action. And if you're really fortunate, that action turns into something that's meaningful and valuable to our society. And in this case, the leap of faith was really created by Drs. Mary Joan Ladin and Nancy Fishman at the Robert Wood Johnson Foundation. We're going to hear from Mary Joan in just a moment. They knew from the literature and they knew from what people were telling them that team-based care made a difference, and it made a difference in quality and cost and outcomes and to the satisfaction of the experience for both patients and providers. And like the very smart women that they are, when they thought about how do we take this, how do we learn from it, and how do we see how practices do it, what can we teach people around the country, they knew that if you want to understand how to do something, you go and ask the people on the front lines who are doing it exceptionally well. And out of that, I think simple but brilliant idea came the LEAP project. In the 5 years since LEAP launched, starting with identifying hundreds of potential exemplary practices around the country, and then narrowing it down to 30, we started with that first phone call, which those of you, Ann and Andy and others, you may remember that first phone call where the team from LEAP interviewed you and made sure you were one of those exemplary practices. We moved on to site visits from the coast of Maine to the coast of the state of Washington, and so many places in between, learning through our national meetings, our site visits, our legendary fish bowls where we all served this fish in the big school where we all came together to learn how to advance team-based care. And I want to give a special shout out to Katie and the Emerging Leaders Initiative that gathered up people from the practices around the country and gave them that extra boost that we so much need for the leaders in our practices. We have been so privileged to advance the art and science of primary care in the country. And for that, on this final time that we're together, we want to honor and thank every single one of you, certainly at the practices around the country. And then we want to come back and thank everybody who participated on the LEAP teams, from the folks at McCall to the National Advisory Committee to the people who went out and did the site visits, analyzed the data, wrote up the peer-reviewed papers, created that amazing website, improvingprimarycare.org, that lives on because everybody who participated in LEAP created LEAP, shared selflessly, as we learned so long ago from Ed in the Health Disparities Collaboratives, and also freely learned and adopted from each other. So I'm going to turn it over to Dr. Mary Joan Ladin for a few words on this occasion of our last gathering as the LEAP community, and then to Tom Bodenheimer for a few last words, and then I'm going to take it back here to wrap it up. So Mary Joan, the floor is yours.
Oh, thank you so much. This has been an incredible journey, the LEAP program. For me, as a nurse practitioner, primary care is a gateway and is the gateway to a culture of health in a community. So I'm passionate about primary care, and I've been passionate about this project. And I think the Robert Wood Johnson Foundation has learned a lot from this project, as well as the country in terms of what good team-based primary care is. I want to take a moment, though, to thank Margaret and Tom and Ed, because the three leaders of the LEAP initiative, excuse me, you know, sometimes philanthropy has interesting ideas, but they don't come to life, and they're not really effective if they're not led correctly and if they don't have good ideas. So thank you so much to Ed Wagner, to Margaret Flinter, to Tom Bodenheimer, and to the rest of the National Advisory Committee and the rest of the LEAP team. It's really been a privilege and a pleasure and really a blessing to me to be involved with this project. So thank you, thank you, thank you.
Great, and thank you so much, Mary Joan, and please extend our great thanks to the foundation for their support over these years, and it's been an honor to participate with the foundation in this national project. Tom, I asked you if you might say a few words on this august occasion as well.
Well, I want to talk about Ed. Ed,
okay.
You can squirm if you want. You can be uncomfortable, but this really comes from my heart. Ed, you really changed my life, because over 15 years ago, I was about to leave my medical practice, and I really didn't know what I was going to do next. And I went to a chronic care model meeting in Seattle. I met Ed and was so inspired that I decided to work on chronic care improvement in primary care. And that's what I've been doing ever since. There's another thing about Ed. You all know about academics. They'll do a project, write a couple of papers, and go on to something else. Not Ed. After developing the chronic care model, Ed spent the next 10 years going around the country and around the world working to get the chronic care model implemented. I would say that Ed is has dogged persistence, cloaked in the clothing of a friendly, loving human being. Thank you, Ed.
Great.
Thank you, Tom.
Thank you, Tom.
Margaret, can I say just a couple of things?
Oh, you sure can. That was coming next, but you go right ahead. You can do anything today.
There's two people sitting on either side of me that have played such an important part in this journey, as Mary Joan called it. Brian Austin to my left, who is blushing, maybe it doesn't show, has been instrumental in making the trains run on time and in organizing our meetings and our work. We could not have done it or even the chronic care model without him. And to my right is Sarah McDonald, the project manager for LEAP, who has been our face to you and the sites and has made everything work so well. We owe them an enormous debt of gratitude, as well as to the foundation, which has been the most wonderful partner we could have had over the years that I can imagine. Back to you, Margaret. Thanks.
Thank you, Ed. And Ruth, this would be a good time to bring up that slide of all of our LEAP sites, without whom the project would not have existed. We came to know you and we came to love you in the course of visiting. God knows I probably never would have gotten to Goshen, Indiana, or down to South Carolina without the enticement of the LEAP project to bring us there. And there were so many people. So Rima, if you could just bring up the LEAP team. We probably not shouted out loudly enough to the people who came together on the National Advisory Committee and all the other people who played an essential role. So Ed, I get the job of kind of the wrap up thank you. And I have to balance my desire to say everything I'd like to say to you with the fact that you made it pretty clear that I wasn't supposed to do a lot of that. So I took a different tack. I sent out an email to everybody who is involved in LEAP, and I said, we could shower Ed with cards and, emails, but I think instead I'm going to give you a challenge. I want you to think about this question and then answer it immediately and send me your answer. And out of that, we'll create a word cloud for Ed as a parting gift. And so the question I posed to them was this: tell me in 3 words or less, or a 3-word phrase, what Ed has meant to you, how you would describe him. And I thought we would share that with you right now. And Tom, you started us off already with persistent and dogged, but I'm just going to read a few of them. Crusty, loved that one. Piercing, invaluable, visionary, idealist, persistent, mentor, force for change, engaging, an exemplar, a clinical and moral compass. He brings order to chaos, and he's irreverent, and he's kind and wise and sincere and approachable. He's a visionary leader, a friend and a mentor, a pioneer, and a major inspiration to all of us, and so much more. So Ed, from all of us in the LEAP community to you, we give you this word cloud. There could be thousands more words to describe everything you've meant to us. And Sarah, I think you have a little something under the desk there, possibly, for Ed if our coordination activities have gone as planned. So Ed, we have for you a photograph to remind you of all the Leapsters and all the LEAP sites. And I think it says on it, as you make this next leap into the future, because we know you're on to great things at the end of June, but we in the LEAP community feel particularly blessed, have had the chance to take this last time that we came together as a community and extend our great respect and affection. I will say for myself, it's certainly been one of the honors and pleasures of my career to go from your being that name on the page about the chronic illness and chronic care model to a trusted friend and colleague. So we thank you from the bottom of our hearts. And now you really do get the opportunity to say the last word to the group.
Thank you, Margaret. I'm obviously sort of speechless, but I'm going to keep talking. It's been just wonderful working with all of these people, and especially Margaret. Co-directing is always a challenge, but it was never a challenge from day one. But I want to close by saying what has made me dogged, crusty, and
bear-like,
and whatever is how strongly I feel about primary care and the people who practice it, and especially the pleasure of working with people like the LEAP people who have made excellence in primary care their daily work. So thank you to the sites and for all that you have taught us over all these years. I'm through. Thanks.
Bye, everybody.
Bye.
Did you